Hey everyone, this is the Manips and Sips podcast featuring me, Dr. Jeremy Boyd, and my partner in crime, Dr. Brandon Cruz. Today we're going to be talking about ACL rehab, what the essentials are in those earlier phases, what we do with our own ACL rehab and reconstructions, and just kind of going over the essentials. But before I get too much into that, let me pass it off to Brandon. How's it going today?
Hey, Jer, how's it going? Everything's going well. Like Jer said, we're going to kind of really touch upon the beginning side. We're probably going to make this a two-parter because if not, I think just this podcast would be way too long. So we're going to really focus on maybe more the manual therapy side, and then on a follow-up podcast, get into progressions and what keys we should be looking for and things like that. But Jer, what drink you got today? I know you had me pick the color green. You gave me the option between orange and green, so I picked green.
Yes, sir. Yeah, you picked Swoosh from Bonesaw, which is probably my favorite brewery of all the 80, 90 breweries I've ever been to. It's in my hometown or business town of Glassboro. This is by far one of my favorite IPAs, probably second to their double IPA. It's called Swoosh. It's kind of a blend between our West Coast and our East Coast IPA. It's really juicy. I'm a fan of those more juicier style IPAs. So I got it here. I'm filling up in my Garden State brewery. Yeah. So you got them both. This glass I went to with my second CI, who I had no idea she was a huge brewery fan. Wendy Jenkins, she was my second CI for not inpatient rehab. Awesome CI, super compassionate. Would never think of it. She's like 5 foot, badass hunter, loves beer. I was like, wow, she's totally the CI for me. But yeah, one day must have been practicing. I think I already started trifecta. We met up, went to a brewery, which was pretty awesome. Got to meet up with her. So yeah, cheers to you, Wendy. And what about you, Brandon?
I have Bib and Tucker. It's a small batch bourbon whiskey. I'm actually gonna have to buy another bottle because this was a gift and I like it a lot. This guy right here. This was a gift actually from my dear friend and office manager Ashley. Jeremy, you had said you have a Bib and Tucker beer. I don't know if they're related in any way, but
well, I'll be adding Bib and Tucker to my beer.
Oh, okay, I got you. So, do you know what Bib and Tucker stands for?
No, I had no idea. I thought it was two dudes.
The little trivia here. It's on the label, so I'm not that smart. But during America's rough and tumble early days, the term Bib and Tucker was used to describe your finest attire. So clearly we're in a finest attire right now.
You know what?
This podcast.
I'm in my finest attire right now.
Exactly. I have this
Sips, baby.
This hat here from Grand Cypress, which you and I went, which is a golf course in Orlando. For all you golf fans out there, Jeremy and I went out there, played around this past year's AOMT in 2019, which was Orlando. So that was a fun time. I think I bought the hat because I didn't have one. I forgot my hat on the plane. Not on the plane, but I just forgot to pack it. Anyway, let's
bought a belt there.
What's up?
I think I bought a belt there because I was like, we were not quite prepared.
Well, part of it was just trimming down on the travel cost.
There you go.
Anyway, so let's jump into this, Jer. I'll let you take the kind of lead here a little bit. Just kind of touch upon your thoughts with ACL. I know you're a little bit more passionate about this than I am. You like this topic a little bit more. So I guess why or what got you so intrigued and interested about it? And then we'll kind of go into some of the stats, surprising stats about ACL, and then what we do to avoid those stats.
Yeah. So I got super lucky. Now just talked about my second AFL. For my final AFL, I got to go to Elite Sports Physical Therapy up in Tin Falls. and I had the awesome pleasure of working under Sharon Wentworth, who owned the practice. Pretty much a dream of a sports physical therapy practice. She started from the ground, small little office, and now it's 14,000 square foot facility. But she was known far and wide for her ACL rehab. Pretty much that's mostly what she saw. And obviously, she got like UCLs, spondylolisthesis, a bunch of other things, but her whole population, if she wanted it to be, could have been ACL. She pretty much had a monopoly on it, simply because of how well she did it and how well her outcomes were. So, being granted, I meant 90% of my caseload at times are ACL. So it was cool. Didn't matter what phases. We had people starting off day one, and we're getting people all the way 6, 8 months out. So fell in love with it. That's probably where I fell in love with the sports side of things. And she just had it down to a science. I can't remember anyone who did poorly on it. Manual therapy, she had it where a physical therapist were doing any of the manual therapy telemobes, extension, flexion, any of your basic exercise to maintain all those sort of things. They drew up the plan, and then she had like masters of strength and conditioning taking them and doing the full gamut of everything: core, return to sport exercise. There's a PT's guy in there as well. But she was honest. She was just like, they know more about exercise than I can ever know. So I kind of hand it off to them, and I'm just there, a couple suggestions if it's something that the athlete needs specifically. So she would like modify some things, or if they had a more interesting surgery, or we had like I think during my time there, we had like a 11 or 10-year-old. So it was a pediatric case. So we had to take that girl a little bit differently than, most of our ACL. So, it was awesome experience. Any of our New Jersey or hell, anyone who's listening in and wants to get more involved with ACLs, I really believe Sharon's probably one of the best PTs, in the country in regards to that. So, definitely a cool experience. So from there, I've always kind of enjoyed it. I've modified things, obviously, with, my own touch, maybe different changing manual therapy and techniques and those sort of things. But yeah, we still see a lot of ACLs at my clinic. And the big thing is, I think, and it's funny when I talk to schools, I guess the DCE, the Director of Clinical Education, and they always mention like simple versus complex cases. And they always throw in like surgeries always under the line of simple cases. For the ACL, I do not think that's the case at all. Even in a situation where I was as a student, where that was 80% of what we saw, everybody was a little bit different, and we had to treat them a little bit different. And if you don't do things right, especially early on, you can really, I hate to say it, fuck someone's life up for the rest of their life. And, even, James Andrews, who's, arguably the greatest surgeon of, of our lifetime.
Most renowned, at least, especially with his him seeing so many professional athletes.
Yeah, that everyone always references Adrian Pearson. Well, Adrian Pearson got back in 6 months, and Drew Brees' shoulder and all those sort of things. That was James Andrews. Even he says, he's like, I don't really do so much. It's really the rehab side. He's like, they see them every day. They work them out, they progress them. He's like, I'm just in there, I do the surgery, and I check up on them every once in a while. So I fully believe that, the ACL should be done and, carried through by people who are extremely confident and experienced. But yeah, obviously have to be exposed to it to get experience. So it isn't a simple condition. It's not just something you can have them do same exercises for a prolonged period of time. They need progression, and they need to be kept a good eye on, because a lot can go wrong pretty quick. So yeah, that's kind of my upbringing in ACLs. I pretty much do a pretty aggressive sort of thing to start off. It's not the most pleasant thing if you ever worked with the ACL. They're they probably don't want to move their legs so much, but understand the things that we're going to be talking about and how important timelines are and how important those early stages are. You're gonna have to push your client, and you have to know to do it in the best way, because a lot of people will quit. I know a friend of mine who's a funny thing is a PT now, tore his ACL 5 times. So,
Same one.
huh? No,
Same
I
age.
think it's like 2 in one, 3 in the other. I
Still a
lost
lot,
track. 5, 8. Yeah, that's got to be easily $250,000 there in expenses.
at least.
Uh,
Probably more.
at least, and then on top of that, the hours, the pain, the
That's
medications.
at least 5 years of
Yeah,
just time rehabbing
yeah.
and things like that.
And as he said, the first couple he kind of blew off. And where does that come down on? Who does it come down on? Is it a young guy who's maybe not taking it seriously, or is it the rehab staff that's not either doing enough or not emphasizing the importance of the surgery itself, or the whole process, not just the surgery? So, yeah, I went on a little bit of a rant there. So, Brandon, what about you? How about
So
you?
good. I'll save my story for our next one, because my course with ACLs, I was very big into it. I mean, I was like obsessed with ACLs. Part of it was I partially tore mine. I had a grade 2, and I had the option of doing surgery and not. But I'll save that story for the next one we do. But I
Oh,
did a
there we go.
capstone on it. Looking at mechanisms, who's more likely to have it. All the stuff that we hope is more basic, but maybe it's not. So I'll touch upon that in our next one. But let me jump into some surprising stats. I think I know when I saw these, and probably when you saw them, you were a little shocked and surprised. I know I was, as this is a surgery that is perfected, right? We have great outcomes, like you said. Adrian Peterson returned in 8 months. He had a quad contraction, or was able to do a straight leg raise like 3 hours after his surgery or something. I think people need to understand that he's a freak of nature, and these professional athletes are just that. They're professional. They're not us. You had touched upon James Andrews, and he usually sends to Kevin Welk, at least I know for a fact, Drew Brees, his shoulder surgery, he went under Kevin Welk, and there's a write-up in JOSPT on it, and you could see what they did. I mean, he was rehabbing 3 times a day. These athletes rehab 3 times a day. I think that goes with what you were saying about educating your patients properly, because they either return too fast, and if they return too fast, they're not ready. And if they're not ready, it's because they probably didn't do the rehab. Just because they've gone timeline wise, they're 6, 7, 8 months, a year out, doesn't mean, just because they've reached that criteria doesn't mean they've reached all the other check boxes that we'll go over. Starting with extension and range of motion. But I'm just going to share the screen right here real quick. Actually, I can't, because you didn't disable it. Can you disable it real quick or no?
Multiple can. Okay.
Good.
Am I sharing my screen right now?
No, I'm sharing my screen just so everyone can see.
Okay.
This slide. Okay, or at least the people who watch this. The people who have to listen. This is what kind of some of the research says. 55 to 70% of people who have ACL tears and surgeries return to a pre-injury level. I mean, we're talking, I'll kind of split the difference in the middle, 60 to 65%. So 40 to 45% of people aren't able to return to the pre-level of injury. That's astounding for such a mainstream injury and mainstream surgery that has been kind of the gold standard and is perfected, or we think it's perfected. I mean, that to me is an alarming number. The re-tear rates are up to 25%. Re-tear rates in 7 months after surgery are 15%. And then I have, increased risk with adolescents and allografts. We won't really get into that. That's a totally different topic. Yeah. But I don't know, Jerry, if you could shed some light what you thought about this guy right here, 50 to 70% return pre-injury when you came across it and started your career.
Yeah, I remember. I think I did my first in-service. I think I have that somewhere on my on my laptop or a flash drive. My first in-service, we all do in-services as students, or usually I have all my students do it because I had to do it. And I think it's enjoyable. Was on ACL reconstructions. I remember coming across those stats and I'm like, wow, that's terrible. Like to think, all right, on the low end, that only half of these individuals are actually getting back to what they want to do. And why is that the case? I think another recent study, I'll try and pull that up. It just came to me, but we'll probably talk more about that on our second podcast. Is I think 60% of individuals after they return to sport, when they go through our standard, as best as what we have right now, return to sport, testing, the single leg hop test, your quad strength return, psychological readiness to return to sport, quad to hamstring ratio, only 60% of those individuals actually, or 60% of those individuals actually failed those tests. I'm not 100% sure on the numbers, but yeah, it was pretty alarming. I'm pretty sure from hearing conversations with orthopedic surgeons and things that the ACL is the most heavily researched orthopedic surgery of all the types of surgeries, including knee replacements, any back surgeries, and all those sort of things. And yet we're at a C to D average essentially with all this.
Really?
So it's pretty alarming. I can't imagine the psychological trauma of going through that surgery, going through that rehab once, but let alone twice. If it was to re-tear, and those stats are pretty alarming. I think there's I forget the exact percentage of you're more likely to tear your contralateral ACL post your first ACL,
Correct.
which is scary. And what are we doing wrong? I think it's that's one thing that I was amazed with being at Sharon's place was a lot of those kids weren't so much a two-timer. There are a couple. Some people just have genetic factors, some females especially, where they kind of are almost predisposed to it, but a lot of them weren't, and it was because of our rigor of what we were doing day in, day out. And saying no to some of our athletes when they thought they were ready. So I think it comes down on us as rehab professionals. I know I've had to say no to probably the last 2 or 3 athletes when they thought they were ready and I said they weren't. So they eventually got back and they've all been good, knock on wood, since. But yeah, what are we? I think the conversation that we should talk about is what are we doing wrong, or what are we not looking hard enough at, or to make sure our athletes go back safe and sound.
Yeah, and part of it may go down to the people who don't re-tear. Well, why is it? Is it because they fall in that 30 to 40, 50% that don't return to pre-level injuries, so they just kind of hang up their cleats. The ones that have the contralateral injuries because they subconsciously know and their body knows that impaired leg or involved leg isn't as strong, so now that other leg is bearing the brunt. But I think when it starts with us, it's at the if we get the opportunity, pre-surgery, pre-op level. And this is another thing where we as PTs need to advocate and educate surgeons, because I've had surgeons, is that popping through? I'm sorry.
You're a you're a popular man. You're like a mayor here.
I have a feeling that's gonna, hold on. Sorry about that.
No, it's
okay. So
good.
Educating our patients or educating our surgeons to let us see these patients sooner. And because they're going to lead to better outcomes. I'm sure you've had like surgeons that have patients not come to PT for like a month out of surgery. I'm like, what the fuck are you doing?
I've had 6 weeks. 6 weeks. I had two starting last year, 2019.
Yeah.
We did not get them to like 5 or 6 weeks. And I was just like, yeah, this is when I was, starting Trifecta and all these sort of things. I'm like, is this like a South Jersey thing? Like, and I was like, all right, like let's, I haven't been experienced with that.
Mhm.
Maybe it allows things to calm down, and they're, they're going to be fine. And nope, both of them, thank God we put a lot of work in, but it seemed more torturous to them,
Oh, of course.
and it was sad. Sad to see. Um,
Um, we'll go into. I just want to touch upon pre-op, and then I want you to talk about
yep.
those 4 to 6 week markers, being that we've both had. And I'm sure we're not the only ones who've had delayed, because you have some good articles that talk about that. But on the pre-op side, you know,
Yeah.
pre-op, there's a study by Morrow in 2008. Pre-op extension deficit predicts post-op extension deficits at 6 months.
Hmm.
So, we want to get these patients in hopefully earlier.
Yep.
Is that the article? Beautiful.
Yep. That's it.
So,
So, um, so if yeah, you just want to take a brief look at this, where we're seeing things is right here. Loss of extension significantly associated with preoperative extension and time from injury to surgery. Um, so that's pretty much what we're talking about here. So this is the loss of extension following anterior cruciate ligament reconstruction. Analysis of incidence and etiology using IKDC criteria by Morrow in 2008 for anyone who's interested. Yeah, everybody who I've had the opportunity to have a prehab with, um, that just from all kinds of things, whether it's just getting range of motion, which is key, because I would say most individuals, you tear your ACL, um, especially full tear, especially with all the swelling, immediately they don't have full range of motion.
mhm.
I Sharon always talking about it, she's like, I can probably tell an ACL tear, like when they walk in, with just their walk. She called it the ACL walk. It's knee flexion, um, their heels raised, they're on their tippy toes. She's like,
Mhm.
I guarantee that's ACL. She called it the ACL walk. And if we're going into these surgeries, and I think when I was a student, maybe my first year, it was like, oh, you tore your ACL, let's operate you. You tore on a Wednesday, we're operating you on a Friday, sort of thing. And now you're starting to see this, hey, we got to at least hold off a little bit. But are we getting them doing rehab? Is it we're just, holding off because there's no time or no spots in surgery? Or are we regaining all that motion back? We had one case um, where we got someone, she tore ACL. She did rehab. She came to the college where I'm at. She got posterior capsule release because she never got full extension. And I was talking to the PT that was working with her. Never got full extension prehab.
Mhm.
They only had her for a little bit. He said he's like, yeah, she wasn't like fully into it. Got the surgery. It got compounded by the surgery. A lot of pain. Want to force your things. Um, didn't do well. Ended up having in that posterior kind of capsule release, and it was still a struggle to get all that range of motion. And could that all been prevented if it was done pre-op? So yeah, if it's something you have the opportunity to discuss with surgeons or anything like that, how important that prehab process is, one from a range of motion standpoint, but two, I like to prep my ACLs mentally. No surgeon to this date that I know of will describe how much of a grueling road this is. Again, everyone's got the Adrian Peterson mentality. People I know don't even know football will talk about something about Adrian Peterson. They'll be like, "Oh, I heard this Adrian Peterson." I'm like, "Do you guys? Oh, like what football team are you like?" I'm like, "Oh, I don't like football. I just heard about Adrian Peterson." I'm like, "What?" So just mentally preparing them. So I'll talk to them about what grafts they need or what grafts they can choose from, obviously go with what the surgeon is, but talk to them about what their surgeon protocol is, and just kind of mentally get them ready for the long road ahead. And, tapering expectations, I think is always a good thing for all our clients, versus coming out thinking, hey, I'm going to be fine. They fixed what they needed to do, and you come out and you feel like a truck ran you over and backed up on you a couple times. So that's why I like the prehab process. But
I agreed that, and even explaining it to patients, those first couple of weeks, just kind of circling back, because surgery, well, let's be honest, it's business, and the surgeon's not going to be like, this is going to be the hardest rehab you've had for the next 6 months. I've had knee scopes, meniscal tears, where the doctors have told the patient, oh, you'll be back in 2 to 4 weeks, no problem, don't need rehab or anything. Doesn't make any sense. PT, when it comes to ACL surgeries, oh, you'll be running in 3 months. Okay, you'll just begin to start to run at 3 months, not being able to go sprint and play sports in 3 months. They kind of downplay it, and maybe that's because they're so busy. And if they do educate the patient properly, a lot of times the patient just has so many other things that they're trying to process that they can't remember it. Or if it's out of surgery, I love when surgeons try and tell you and educate you right after the surgery. And I don't know if anyone's had surgery before. You don't know what's going on. It's like being like blacked out, drunk. The patient, you're woozy, you're trying to come to, and the doctor's just speaking a mile a minute, and you're just like, yeah, whatever. Like, you don't remember. So, obviously they're limited on what they can do, but they need to rely on us a little bit more. And I'm not saying every surgeon's like that, but so we've had our fair share, more than our fair share, of surgeons who don't either use us properly as therapists, or kind of don't educate their patient properly. And kind of last thing, I know we're talking about extension here, but a couple other studies that talk about preoperative strength deficits predict post-op strength deficits at the 2-year mark. And then we want to normalize a joint. And Jay, I know you want to talk about this later. Preoperative synovitis correlates to post-op arthrofibrosis and or arthritic changes and things like that. So, transitioning now, let's go into those phases, and let's go to phase 1, which would be kind of restoring motion. When's the optimal time, Jeremy, that we should restore motion? How can we restore motion better? What does restoring motion actually do? Let's kind of touch upon some of that stuff.
Yeah. And just to piggyback off what you said, some of that quad or that strength sort of thing, I think that was probably the most important thing. Prehab is you can really work that quad, and no matter how good you are, once that surgery happens, that sucker turns to mush on most people. Yeah. But I feel like the individuals that kind of get it in their head, I'm like, I had one kid, I didn't think I was going to be able, we didn't see him prehab. I was just like, listen, he was just like scouting us out. This is when we were in the dungeon trifecta. I was just like, listen, I don't care who you pick, but if you can get any advice from me, get your knees straight and fire up your quad. And I showed him like a quad set. And while I was talking with his mom, he was just like firing up his quad, he was like getting used to it. And then he did decide to come to us, and day 1, you can just see him just doing it. And literally anytime I left him to do an exercise or show somebody something, that's all he was doing. And his outcomes were great. But yeah, that phase 1, super pivotal, that getting that range of motion. It's a big if of when to start. Obviously, these individuals are in a lot of pain. Most of them are on the nerve block. So those first 2-3 days, they can't even feel their leg, which is, I always think, I'm like, maybe that's the best time if you can come to their house for a little bit, do some things. I know some surgeons use a CPM, not too many do. So, I always consider it. I'm like, all right, they're on their block, they don't feel anything. They're also probably on some sort of, opioid or anything like that. That's probably our golden hour. But yeah, I usually like to, at least within the first 5 days, try and get them in. I did see one ACL as a student the day of. I don't know if you ever got that, Brandon.
No, never got that.
The day of the
As an intern in Florida, I lied, but not as a practicing clinician. No.
right, and yeah, same here. And the surgeon insisted, and I was like, wow, that's pretty awesome that he believed in therapy, wanted it started day one. However, one of her portholes, which obviously it was the day of, didn't fully seal. I think she was doing like quad sets or something like that, and then that like classic, movie where it's like blush was shooting out, wasn't shooting out, but she was leaking everywhere. So that pretty much shut down the session. But yeah, getting in and starting within that first week, I think is absolutely critical. And I'll always put more emphasis on extension over flexion every single time. Unless I get someone says, the surgeon was like, hey, maybe they have some OCD lesions or anything like that. I haven't had that. Where extension wouldn't be beneficial. So I'll tell the clients, and I think the big thing is most clients, because they can see progress with bending, it's an easy sort of thing, and, especially if you're the PT and you say, how many, you're at 120 today, they fixate on that sort of stuff. They'll emphasize that more. And it's really up to us to emphasize the importance of getting extension, not just to neutral, but to whatever the opposite side is. And most of us, especially our female athletes, they hyperextend. So leaving it at neutral is not enough. So yeah, that's something I do. Obviously, I'll start off hammering home extension, and then we know based off of like our quad inhibition studies is we cannot fully activate the quad until we get full extension. So I spend a good deal of time, and for those individuals, probably 20, 30 minutes, if I can, doing some sort of manual therapy, patellar mobilizations, because you do need the patella to go in the superior direction with quadriceps contraction. Scar tissue, just kind of big debate of whether you're breaking that up or not. And then, getting, extension. Obviously, maybe those first couple of days you're not going full ham and pushing it all the way to hyperextension, because they may be a little bit too uncomfortable. And we know when we go way too aggressive too soon, you may cause some arthrofibrosis, but you at least got to push it, because we know how the human body and brain thinks. They're typically not going to push themselves to that, to those end ranges. It's just, especially that closed pack position of knee extension, people aren't going to push themselves. So it's our job to do it, just grade it. So I'll start maybe with some tibial femoral, just the tibia AP mobilizations early on, and then get a little bit more aggressive with the femur and a tibia at the same time, sort of thing. But that's kind of my first process. What about you, Brandon?
Yeah, I think in phase one, we have to, obviously protect that graft and focus on mobility. I think one of the reasons, or another reason to add on to what you were saying, why patients focus on flexion more is it's also less painful. Hence that gait with the knee flexion and things like that. Talking about patella mobility, manual therapy is going to help decrease pain. Decreasing pain, increasing range of motion is going to help better quad activation, as you were talking about. And we have some studies here by Noel in 2000, Delhi in 2000. Obviously, we want to try and encourage weight bearing as tolerated as fast as possible with that. Jared, do you have those articles queued up? I'll talk about real quick just these stats here, and then you could maybe just show the articles.
Yeah. I was going to show some of the manual therapy that we do initial on, but let me get this one up. Oh, you got it up first? All right.
So, well, if you could show the articles or even put it in the link. This is just from a PowerPoint. I had it queued up, that's all. So, the 25% of patients had less than 5% loss at 4 weeks, and that's that first article that you're talking about by Morrow. 12% of patients have less than 5 degrees lost at 2-year follow-up, and 10 to 14% have greater than 3-degree deficit at the 7-year post-op. And then we have, this is a key one. I'll let you talk about this, Jer. Extension loss at 4 weeks post-op predicts extension loss at 12 weeks post-op. And you were talking about not getting the ACL patient until 4 or 6 weeks later. Well, that kind of we miss out on this window here.
Yep. So yep, I have it already. I'll share screen. Is this it? Is it? Yep. So, yep. No. This is the article, right? Correct. Yeah. So basically, what they saw in this study was, what we get at 4 weeks kind of was a predictor of what happens at 12 weeks. To sum it up, that if you weren't within, I believe, 5 degrees of, you didn't have to get all the way to full knee extension within 4 weeks. But if you did not get within 5 degrees of it at 4 weeks, the likelihood of you getting it at 12 weeks was significantly reduced. So that's pretty much what they found with this. This is knee extension range of motion at 4 weeks is related to knee extension loss at 12 weeks after anterior cruciate ligament reconstruction by Null, I believe in 2012, right? It was 2012?
I thought it was 14. It could be 12.
2014. Sorry. No, 2015. 2015. Sorry. That's pretty much what I got out of that article was, you have that 4 week window. Unless they're in a knee immobilizer into full extension. And let's be honest, those hinge braces that they all come out with, and they're set to 0 or hyper extension, not a soul is ever in full extension. They find a way to have their knee bent in there. The braces are not, the best design, but that's what we have right now. So yeah, you just I try and ideally, some things I've tried to do is, obviously I'm doing all the rehab outside of the brace. And then before I let them go, sometimes I'll do some knee extension, either exercises or techniques, manual therapy wise, before I let them go, and then I stick them back into the brace. But yeah, if you're missing out on this 4 week window, it's going to kind of mess them up. And then at 12 weeks, what are people going to want to do? 12 week is the running phase.
Typically the running phase. Yep.
Have you ever tried? I want everyone to go out there. Don't injure yourself or anything, but try running with one normal knee and try running another one with a slightly bent knee and see how that feels on you. You're not going to feel great.
Your hip and your back too.
Hip, back, knee. You're now ruining the whole kinematic chain, and you're just going to be loading up that knee over and over with hundreds, if not, we think, oh, yeah, we do 3 sets of 10 or 5 sets of 10 reps. Running is hundreds, if not thousands of reps over and over. If we're not doing it with, the proper kinematics, it's just going to keep beating up that person. They get inflamed from that, and their knee swells up, and now you've gone back 3 steps. So yeah, go ahead there, Brandon. I'm gonna.
I was just gonna say, I believe running's well, depending on the speed you're running, anywhere from 6 to 10 times your body weight, and I think it's like 7,000 to 10,000 newtons of force that's going through that kinematic chain that needs to be absorbed. Jerry, you talked about a good point, that brace, and it being locked at 0. I guess, do you want to touch upon, or do you have handy a couple of studies that talk about locking people into 5 degrees of extension and what these people look like? If not, I have the study or a slide for people. But I
didn't know the slide. Go fire up the.
Because you said, is that something you try and do? Is bring them to beyond extension or beyond neutral?
Yeah, always. I mean, within the brace and everything like that.
Yeah, instead of locking them at 0, can we lock them at -5?
Ideally, yeah. I try to get it. I mean, some of the braces I've noticed just go to 0. I've seen a couple where I don't know if it's Donjoy, I can't remember who, will have a couple hyper extension into their brace.
Yeah.
So, yeah, I try to, if it's whatever it may be, I try and get them as straight as they can, and then put them into the brace. And if we can lock them into hyperextension, that's ideal.
Yeah.
I don't. They have dyna splints and stuff like that. That's obviously not a brace. It's something that the client can use to get hyperextension. But I would think, hey, if we had some sort of combination brace between like the dyna splint, um, and your standard, post-op ACL brace that can get more hyperextension, we'd I think our outcomes would actually get a lot better. But
Yeah.
yeah, go ahead, Brent.
So yeah, just this study just talks about locking people out at -5, and the people that were locked out at -5 had 9% of them had extension loss of greater than 2 degrees at that 12-week mark, versus 54% had extension loss of greater than 2 degrees at the 12-week mark. I mean, I think that's a huge thing.
Huge.
But I will say with this, maybe not every patient needs this. So you can't just take this article and be like, lock them at 5, because like you said, if you're too aggressive, it's going to lead to some fibrosis and, irritation of that joint. So we need to learn how to pick and choose what patients we think need it, and what patients we don't, or when to use it as well. Because, some of those people who have their ACL tears, or ACL surgery, and they're not really athletes. They either A, just like fell down the steps or something, or B, maybe they tried to go play a sport one day and it just didn't work. Like they're going to have a longer and tougher road. They're probably not the athletic type and know how to push themselves. And I guess the best way is you'll know those patients when you get them. So yeah.
Yeah, it's always something to, base your treatment off of who you have, what their goals are, and everything like that. Yeah, obviously someone who's got D1 or collegiate aspirations or professional aspirations, they're going to do whatever you tell them to get there. Someone who just wants to go back and, you know, occasionally run around with their kids, it's a little bit different. So forcing it too much, even as it is a goal, and putting them through a great deal of pain might make someone, bail out, not complete the rehab, and now they're even more at risk. So definitely grade it based off of who you have in your clinic.
One thing I try and educate my patients on as well is put things in perspective, for letting them kind of, adding what you were saying, Jer, and kind of telling them the road ahead. We're lucky if we get a patient 3 times a week for an hour or so a week. So we're talking from like 3 to 4 hours a week. There's 169 hours in a week, right? 169. I'm not sure if that math's right, but you get what I'm saying.
Mm-hmm.
4 hours out of 169 or 170 hours in a week is not enough for us to, or not enough for the patient to just do the bare minimum. They need to be able to go home and do some things. And if you break it down, like we're like a small little percentage of this pie, and we're here to give them the tools and knowledge they need to become better. That's going to benefit those patients in the long term, in the long run, especially in early on phases when they want to put the pillow underneath their knee while they're watching TV, and you're like, no, put the pillow or roll up towel by your ankle or your Achilles. So you can get that, strain, stress, creep, prolonged duration, low load, knee extension. But I know I don't know if you had anything else to say, but I know you wanted to show some videos on some mobilizations kind of use.
Yeah. A good thing I tell my, it's obviously mostly athletes, is I tell them it's their full-time job. Is your ACL rehab becomes your full-time. I'm like, yeah, make sure you still pay attention to your studies. But it is a full-time job because it needs to be a full-time job. Those 6-month, Adrian Peterson people, it was their full-time job. They did rehab 3 hour, 2-3 hours up, tapped out. Oh boy.
No, I'm refilling here.
Oh, refilling.
Almost. I probably got a little bit left.
I might as well rip a shot then. Some nips and sips. So I'll show kind of I'll start with some patellar glides. I'll put up some the knee extension, technique that we do once they're a little bit more, I guess, seasoned. I wouldn't go gung ho on this, but let me put that up real quick. And again, anybody listening in, they can, feel free to, come back, watch these videos. And 1 second, share screen. Here we go. And so sorry for the.
Is that an ACL patient or is that Justin?
No, that is a ACL client. He is a pretty awesome one. He's one of the first ones where they used and salvaged a piece of their ACL. I'll talk more.
So, Jer, can you talk about, because I do this too. I don't know if everyone can see, and if you guys are listening, Jeremy has like a foam pad or a rolled up towel I use underneath the patient's knee by the popliteal fossa, which I think is a great way to help, I guess, make the technique more comfortable for patients while you're doing extension mobs. Jer, if you want to just touch upon that.
Mm-hmm. So yeah, I ran through all my. Oops, we don't need to hear me talk again. Yeah, I ran through all my patellar mobilizations in about, it's give or take 20 degrees of flexion, which we know is the open pack position of the knee joint, which again is why a lot of people will stay to a bent knee with walking and everything like that. So this is something I do. I used to probably start off my patellar mobilizations in full extension. But yeah, test it out. First get them full extension and see how much easier it is to mobilize and move that patella around in just 20 degrees of flexion. And it's going to go a lot easier. The patient's going to be a lot more comfortable. Maybe as they gain more pain-free extension, I may start to remove that because I do need to fire up that quad in full extension and get that patella moving. But this is something I'll start off with. Just to kind of get things moving, and it seems like it's again a lot more tolerable. You don't want to, you want to limit or eliminate as much pain as possible with any of your manual therapy. Sometimes you do have to push them a little bit, like I have to do.
They're already guarding. I'll say with that, Jer, I like the rolled up towel. Let me backtrack real quick. You touched upon just mobilization in general, make it more comfortable for people. They're already in pain. Doing a mobilization in a pain-free range or 20 degrees of flexion is still going to have carryover into their limited range, especially in someone who's lacking motion. I use a rolled up towel because you roll up the towel, your typical hand towels you have, and then as I go along and as I'm getting a little more of a balance and that pain's decreasing and the patient's not guarding as much and you're getting more extension, I unroll the towel a little bit. Now I'm getting a little bit more into extension, mobilize there, unroll the towel some more. So, you're starting from a wedge that's like this big and you're going, down to, more extension. And then, like you said, obviously end rate extension. But yeah, I think that's a good piece of information or golden nugget for our audience who's, maybe don't find manual therapy that effective. Well, is it because you're trying to crank on this patient, in pure knee extension? So if you try that tip, it might help you be a little more successful.
Yeah, definitely. I used to be that person that was like, all right, we're gonna go for the full thing every day, every time they come in. And that's when people begin to dread it. They'll probably cancel on you. So if you can grade it, chip away at, just like your exercise, you grade everything, you advance it. Same with your manual therapy, is this slowly chip away at it. And then when they're at 90%, feel free to go gung ho, which would be
so,
this.
Yeah, I'm looking at the videos here. I'm going to guess this was in the middle of COVID here because you got black gloves on. Is that right? Were you seeing this patient during Corona here? Or
this is before it really broke out.
Okay.
Like, so he started in early post-op, early March. So this is probably like, within a week or two of his probably 2 weeks, because his steri strips are off.
All right.
And then after that, I've been starting to use like masks and stuff like that. So,
Okay.
yeah, if
I just
there's a
noticed the gloves.
scar,
I was like, yeah, that's got to be recent.
yeah. Well, sometimes if I know, like, you see here, there's a scar and stuff. If I'm going to be digging into someone's scar,
Yeah.
I'll usually put on the gloves. So
Okay.
I think this was probably week 2 of his week. I want to say it was probably week 2
All right.
of his surgery. But black gloves make me look a lot slicker than I really am too. So you go into a restaurant, you see the chef with the black gloves, you're like, oh shit, he's for real, and it could be awful food for all you know. But those are
Rebo
that's
effect.
those. Yeah. Now actually my gloves are blue. So actually since COVID, we ran out of black gloves. But these are some quick exercises. I'm going to show this is a way to, there's big debate about ice and everything like right now. Obviously, you want to do everything in moderation. Too much ice, you're shutting off um, the proper healing process that inflammation does give. A lot of people post ACL are like icing an hour long, pretty much all throughout the day, and that might be too much. And then you got people who don't do it at all, and their knee swells up, and that we know anything more than 3 centimeters of swelling within the knee joint can cause quad inhibition. So you want to be somewhere in between where you're allowing the healing process, you're not getting hypoxic. So this is just not even gonna play the videos. His knee's straight. This is actually pre-op. So this is sometime in February. And his knee's straight. We're gonna get that, that creep effect with our stretching, a prolonged low load stretch. He's got a compression ice device. I'm teaching this all to him before he's getting into his surgery. So, I mean, he was probably 140 degrees or 100, he was probably 120, 130 degrees within like 4 or 5 weeks.
Mm-hmm.
Full, extension to zero and those sort of things. Why? Because he got such a head start on things. I taught him patellar mobilizations, which, yeah, and you hear me talking to him. What I can be honest with is how difficult it is for a patient to self-mobilize their patella. It's, you can teach them, and then all of a sudden you watch them do it like a week later, and they're just moving the skin around. So that, again, that further emphasizes, we can teach self-mobilizations. I love to do that. But we got to be honest with ourselves of what the patient's really going to be able to do. Are they really going to push themselves? Are they going to do it with the right technique? And that's where manual therapy comes in. Heel slides, quad sets, firing up that quad before, and then if you have quad, straight leg raises. So, and then all that, and all that, and I was able to coach him with things, kind of get fired up into his brain before, obviously he went in for surgery, and everything had its effect. So that's something I like to do, and I wish I can do that with every ACL client I ever had.
Yeah, the ones that are motivated definitely more fun. Yeah, I saw you doing heel slides. I don't know if you have the article handy. If not, we'll add it in part 2 of this this topic. The one that talks about heel slides being as effective, if not more, than a CPM machine. CPM machine, and that's just a way to help save our patients money, not have to rip through the medical, I guess, insurance and things like that. And it's something that the patient can start day one and not need to be fitted and have someone come to their house and all this other shit. Just have them do heel slides. Nice, easy thing. And like Jeremy said, attack the quads. Pro and TKEs work as well. We have this
That's a good
patient
one.
on their stomach, having them stand against the wall and push into a ball, whatever works. But we do know that, inadequate quad strength will result in an altered gait pattern, and that's going to lead to altered running patterns and really just prevent us from being able to transition to phase 2, which is where we really want to focus on strength and endurance and symmetry and things like that. So we'll save that for the next podcast, which will probably be a little longer because there's a lot more to cover. But I don't know, Jared, do you have anything else? I think that's pretty much it, right?
No, I think we did a good job of hitting those first phases, and hopefully give some insight and of what to do. And if you have any questions, you have a tricky ACL, or you are an ACL client, want to talk about some things, feel free to reach out to us. We'll obviously love to nerd out about this sort of stuff. We're at Nips and Sips on Facebook and Instagram. I'm at The Decent Doctor and at Trifecta Therapeutics, business-wise. Brandon's at Think Like a Fellow and at Pursue PT Now. Feel free to reach out to us. Hopefully gain some nuggets of knowledge here. And thanks for listening in, everyone.
All right, guys.
Cheers.
Cheers.